Saddle up for a wild ride, VETgirl Pack. We're headed to the heart of Music City for VETgirl U next summer. So mark your calendar to join us for a rootin' tootin' good time, June 27th to 29th, 2025 at the Renaissance Nashville Hotel. We're bringing the heat with hot chicken, honky-tonkin', and some seriously amazing CE. Hi, VETgirl here today, and super excited to talk all things critical care. Today, really excited to be speaking with Dr. Jamie Burkitt, who's an emergency critical care veterinary specialist just like myself. Jamie and I go way back to University of Pennsylvania over 20 years ago. Jamie, thank you so much for joining us today.
Thank you so much for having me. It's a pleasure to be here and to see you again after such a long time.
I know it's amazing how fast 20 years flies by, and I reflect mostly positively on my experience back in Philly. So anyway, I wanted to, first of all, talk to you about Recover, and I know there's a Recover 2.0, but before we do that, just so our audience knows a little bit more about who you are, do you mind giving us a little bit of background about who you are, where you trained, and what you do now?
Yeah, sure. Thanks. I'm Jamie Burkitt, and I publish as Jamie Burkitt Creedon because that's my legal name, but I generally practice and kind of know everyone in the field as just Jamie Burkitt. I am currently an associate professor of clinical small animal emergency and critical care at UC Davis, and I've been here this stint since 2017. In fact, it's where I started. So I went to vet school at UC Davis, graduated in 2000, did my internship at Penn, Justine, which is where you and I kind of know each other from, my rotating small animal internship there. And then did my residency back at UC Davis, finished that in 2005, and then actually worked as a faculty member at Davis for a few years before leaving for private practice, and worked in private emergency and specialty practice for, I think, about 9 years. Between Northern California, New Jersey, Texas, Oklahoma, back to Northern California, moved around a lot for a while. And then, been back at the university, like I said, since 2017. Joined Recover, and I actually have tried to figure out when I started working with Recover. I think it was 2019. So that's a little bit about me.
Awesome. Well, thank you so much. You know, I wanted to talk to you about Recover, and most people in ECC know what it is. For those of you guys who don't, I definitely recommend going to the recoverinitiative.org website. And Recover stands for Reassessment Campaign on Veterinary Resuscitation. And this originally came out in 2012. I know so many criticalists who put so much work into this, but this was really pivotal because it really gave us evidence-based medicine on what we should do when it comes to cardiopulmonary resuscitation, or what I'll call CPR from now on. And I understand a 2.0 came out. So compared to the 2012 Recover guidelines development process, what was different about the Recover 2.0 project?
Yeah, that's a great question. So I should give all the props to Dan Fletcher and Manu Bowler, who ran the entire 2012 initiative, which I did participate in as an evidence evaluator. And I'm sure many other criticalists kind of my season in life also did the same. And so when they decided that they needed to update the guidelines, they decided to bring on a third co-chair. So we call ourselves co-chairs, the kind of academic pillars of the Recover Initiative. We have the guidelines co-chair, and that's me. Manu Bowler is the research co-chair, and Dan Fletcher is the educational co-chair. So we work really as a team and work together in the initiative, but they ultimately brought in the newbie me around 2019 and had me, in theory, be the person leading the guidelines charge. So I think that's one thing, was the addition of a third co-chair and more defined roles for the three of us. And then another piece of it that was different, and really probably the most substantive difference when it comes to what the product is in the guidelines, is the fact that we use the GRADE approach, which is an approach to evidence evaluation and development of consensus guidelines like the Recover CPR guidelines, where different primary literature, so studies that are the primary research study, not a review, not some kind of analysis of it, but rather truly primary literature, undergoes evaluation by two independent professionals. And in this case, we recruited over 200 veterinary professionals, and those are board certified critical care specialists from around the world. So ACVEC and ECVEC, and some Australian board certified emergency critical care specialists, in addition to some anesthesiologists. And I think we had a smattering of cardiologists in there as well. And we also use the really valuable help as well of veterinary technician specialists. So registered and licensed veterinary technicians or nurses who are specialists in their areas contributed as well. And then after going through the evaluation process of the literature, and they evaluate each primary study in the area for areas of bias and rigor of the study in general, make sure that the study is actually applicable to the species that we're talking about. And in this case, that was primarily dogs and cats. And then ultimately, they write a little summary, basically, of what they thought of their literature and what they think treatment recommendations might come from the literature they reviewed. And then the three of us co-chairs, along with the chair of each domain that was either basic life support, advanced life support, or monitoring, worked together to write up the summaries that ultimately appear in each domain paper: basic life support, advanced life support, and monitoring, and in the Recover Guidelines document itself. So it was a much bigger lift doing it this way. In 2012, each question was only reviewed by a single person with no specific instructions as to how to review that literature. The GRADE approach is far more rigorous, basically, and in depth, and took a lot more time than we expected, especially when you throw a pandemic in the middle of it. And so this time was a lot more rigorous, a lot more work, but we also developed a process that we anticipate we can use to move forward with future guidelines development.
You know, I saw the call for Criticalists to weigh in on it, and I just wanted to first give a shout out because I know how much work it was for Manu and Dan. Go Penn, right? We all knew each other from Penn.
That's right.
And the amount of just review and critical analysis to be able to provide something that's evidence-based is so important. And that's why I want to talk to you about it. Like, obviously, the size and scope of the project is huge. So thank you for giving us an overview of that. In terms of the literature being reviewed, the number of subject experts, again, huge, huge project, huge amount of time, knowing you guys have been working on this for years. So give us a lowdown. What are the major changes in recommendations for veterinary CPR in the updated Recover 2.0 guidelines?
Yeah, that's a great question. So we knew that we would come across some differences between what we recommended in 2012, which was the reason that we undertook the project in the first place. We knew that the guidelines needed some refreshing. But I think that we had some pretty significant changes, and more than I think we believed that we might have. In basic life support, we had a few changes, and that largely was in the options for methods of performing chest compressions. So we recognized that the main way that we had recommended chest compressions be performed in small dogs and in cats in the 2012 guidelines was this: brace the back with your non-dominant hand and use a single hand with fingers and thumbs opposed, kind of in a V shape, to perform compressions over the heart. And I think this is one of the advantages of having brought a woman on to the group, because I think I started out when we were writing the guidelines saying, guys, I got to be honest, I never do it the way you tell me to do it because I physically can't. So my hands are too small. My hand is weaker than yours and it fatigues way shorter than 2 minutes into a cycle. I cannot do what you tell me to do. So I have to do something else. So we looked into different evidence of different methods of chest compression. And of course, because almost all of the evidence that is available is from human beings, all of whom are pretty much shaped the same. We're all pretty much shaped like bulldogs, like English bulldogs with these flat, wide thoraxes. There really was not a lot of evidence. So this ended up being an opinion-only recommendation, basically expert opinion, based, of course, on the domain chairs and the co-chairs and the consensus of the broad critical care community that we gathered in August and September of 2023. But ultimately, there are now three ways that are sort of recommended or possibilities for how a person might perform chest compressions in a small dog. Say it's all relative, right? Depends a little bit on how they're shaped, but probably for me anyway, probably 7 or 8 kilos or smaller as a dog or any cat. Three different methods that we recommend, and we have drawings of those in the basic life support, I think the basic life support domain paper, but it may only be in the guidelines. So yeah, we wanted to introduce those different options so that people did not default to hand over hand, two hand compressions of these small animals, which was the other main recommended position, because we were concerned about the possibility of overcompression. So overcompression is a thing. It turns out when you read the literature in people, there absolutely is evidence that the effectiveness of chest compressions forms kind of a parabola. So there is certainly too weak chest compressions. You don't push hard enough. There's no doubt you are not going to move blood through that heart. But if you push too hard, there also is a decreasing effectiveness. Even if your rate is still good, even if you're still hitting your other targets, if you overcompress, you also decrease cardiac output, basically. So we knew that in people, they had found that a depth of approximately 5 centimeters was ideal. But there really are hardly any dogs that are truly shaped like people in both shape and size. So the three of us co-chairs spent some time examining human CTs with the appropriate slicing to figure out, what is 5 centimeters on a percent basis? What percent of the thorax is being compressed? And what percent of the compressible thorax is being compressed in a person? And we determined that it's approximately 1/3 to 1/2 the compressible portion of the thorax that's being compressed in people that gives you that very best cardiac output, which is where we came to the lateral recumbency, 30 to 50% the width of the thorax recommendation. But then when you turn the animal into dorsal recumbency, so instead of being lateral, they're supine, just like a person would be during chest compressions. When you evaluate that, you realize there's a lot more non-compressible tissue in that orientation because you have the spine and all the apaxial musculature, some adipose tissue that is probably collected appropriately across the back, that if you're doing it in lateral recumbency, you just don't have nearly as much of that non-compressible tissue. So what we figured out, or we believe to be true, this is all expert opinion based on extrapolation from human CTs and recommendations in people, is that if you have a relatively wide-chested dog, like an English bulldog, that it is most comfortable and easiest to perform compressions in dorsal recumbency, that you really should probably only be compressing about a quarter the depth of that thorax on each compression. So that's another new recommendation in BLS. Those are really kind of the two major new recommendations in basic life support.
Awesome. Great information. And so glad that feedback of the majority of females having smaller hands, right? Not to stereotype, but being that vet med is 70% to 80% female, this is a really, really important aspect that you were able to weigh in. So thank you. Any other changes that we need to know about?
Those are the big ones in basic life support, although I'm sure you have an international audience. And I do want to point out, because this final recommendation in basic life support was made mostly with a nod to the international audience, is that we did also move away from a primary recommendation of mouth to nose ventilation for single rescuer CPR and instead move to a tight fitting face mask. And we do that specifically because particularly in areas of the world where rabies vaccination and other vaccination and general pet care may not be as robust as it is in the United States and Europe, there are certainly diseases that veterinary professionals have to worry about potentially catching zoonotic diseases from animals they're trying to resuscitate. So that group said, please let's not be doing any more mouth to nose breathing. So we moved to tight fitting face mask. The other group, of course, we have to worry about that, and this is true in the United States too, sadly, is drug sniffing dogs. So any dogs that have arrested secondary to inhalation or exposure to large doses of narcotics where it may put the rescuer at risk. So we also changed that as well. Some advanced life support recommendations too. So advanced life support is actually the place where most of the changes occurred. And I think one of our major ones, for me, the thing that will be the biggest change, I think, is our minimum end tidal carbon dioxide target. So our minimum ETCO2 target during chest compressions. I don't want to mention what it was in the old guidelines because I don't want to get anyone confused, but we know that we want to be performing chest compressions adequately enough that we are able to generate an end tidal CO2 of a minimum of 18 millimeters of mercury during the compression phase, our 2-minute compression cycle of CPR. And that really is a minimum. And it's Dr. Bowler, it's Manu, who's really the main person who said, we can't stick to this number. What we need them to know is it needs to be more than that number. So the evidence definitely showed that human beings that are able to achieve an end tidal CO2 of 18 or more during CPR are much more likely to survive with a good, favorable neurologic outcome than those with end tidal CO2s under 18.
Now, expanding on that, is that because people are hyperventilating them? You know, the panicked vet student who's like has an ambu bag, it is, giving one breath every second, or is that related to brain CO2 and vasoconstriction? Do they know the mechanism of why greater than 18 on an end tidal is associated with higher survival in human medicine?
Yeah, that's a great question. So, I mean, the real answer to this, because the evidence that we used is all gathered from human clinical medicine, almost all of which is large retrospective, or it was prospectively collected, but it was not aimed specifically at end tidal CO2. So rather, end tidal CO2 was kind of studied as a side part of the study. The truth of the matter is that the why of this is assumed and is not necessarily actually known for certain. But what we believe, because during CPR, as long as you do hold your respiratory rate and tidal volume constant, so in other words, you are regimentedly or religiously giving one breath every 6 seconds to an appropriate chest rise, the ventilation aspect of CPR remains relatively static. And even when those perfect conditions are met in these studies, so in other words, it's not hyperventilation that's the problem, even when these perfect conditions are met in these studies, it is found that the end tidal CO2 of 18 or greater is associated with better survival and favorable neurologic outcome. And almost certainly that's because as long as you hold ventilation completely constant during CPR, that end tidal carbon dioxide ends up being a circulation monitor. So what you're really monitoring there is return of little aliquots of blood from the periphery. So from the gastrointestinal tract, from the feet, from the extremities and limbs and the muscles of the limbs. You're returning little aliquots of blood from those areas. And remember, that blood will have sat near cells that are performing, aerobic and anaerobic metabolism, and all the aerobic metabolism that's being performed is going to produce carbon dioxide. So the little aliquots of blood sitting out there are really rich in carbon dioxide. And so what it really means, if you get a nice higher carbon dioxide in your end tidal CO2, is that you are performing chest compressions in a way and performing basic life support in a way that is adequately leading to appropriate cardiac output. And so new blood is being adequately forced out of the thorax and all the way out to that periphery, displacing that carbon dioxide rich blood. And that carbon dioxide rich blood is being delivered to the pulmonary circulation and exhaled and measured by your capnometer, capnography unit that is attached to your endotracheal tube. So it's weird because in vet school, we're all taught, CO2 is a measure of ventilation, which of course it is. But if you hold ventilation static, carbon dioxide measurement at the end of an endotracheal tube is in fact a measure of adequacy of perfusion. So that's really what we think it is how well are the heart and brain and lungs being perfused based on a team's chest compression technique, whether or not the animal has adequate intravascular volume, so, adequate blood volume and things like that. So that's really what we think is going on there. And it's pretty awesome. And probably that 18 target is our biggest. I mean, I'm biased. I'm so biased on this, but I think it's actually our biggest, most important change that we've made this year in these guidelines.
That's great. So good to know. All right. Now, when it comes to veterinary CPR, what knowledge gaps remain out there?
Oh, that's a great question and an easy one to answer because the answer is almost everything. Almost everything that we recommended was either based on indirect populations, that's how we call it in the grade approach. So not dogs and not cats, and certainly not dogs and cats in a clinical setting. We did come across some literature, some studies, experimental studies in dogs and cats, but that was even the minority of experimental studies, most of which are performed in swine and some in rodents as well. But even the dog or cat in the experimental laboratory setting is not anything like a dog or a cat that arrests in our hospital. So really, really indirect evidence was used in order to make these recommendations, in addition to expert opinion. We're trying so hard to get away from expert opinion. We want evidence, but when there is no evidence, expert opinion is what we use. But again, we did try really hard with the expert opinion to get really deep into it. I mentioned, reading all those human CTs, trying to figure out what percent 5 centimeters was of a human thorax. So we tried pretty hard to be good about it. And again, got consensus from the international veterinary community. But we have so many knowledge gaps and a lot of what I think we would consider low-hanging fruit as far as future study. And we've included a lot of those knowledge gaps in our domain papers and a few really big ones in the discussion section of the guidelines, hoping to get really interested people in the veterinary emergency critical care community keen to work on some of these projects. And to that end, Recover also gives grants on an annual basis for CPR-based veterinary research. So we're always looking for people to give money to in order to forward this cause.
Awesome. So I know you talked about projects. Are there any specific projects that Recover has going on now in research, education, and guidelines development?
Yeah, thank you for that question because this forwards our mission. So I'd like to be able to answer this one. Dr. Fletcher, Dan Fletcher, our education co-chair pillar, he has been diligently through this summer after the guidelines were published working on updating the basic life support and advanced life support online courses to match the 2024 CPR guidelines. Those are now available. People who are already CPR certified, so those people who have already taken courses are able to recertify at a discount for a period of time. They were able to do that. We are really excited to be able to offer these online courses already to people. We also have started to educate our instructors as far as the updates of the guidelines so that we can build new in-person modules and people can begin to be certified in person. So as rescuers, CPR rescuers with the most updated information as well and the most updated recommendations. So Dan is busy. We also recently released a post-cardiac arrest online course. So I think it's a 1 or 1.5 hour, and so thus 1 to 1.5 unit CE credit online course in post-cardiac arrest care. So that's really exciting as well. And our next projects, Dr. Bowler and I are working to finish a newborn resuscitation unit. So that's focusing on puppies and kittens at this time. And newborn resuscitation covers not only true cardiopulmonary arrest, but also just kind of the floppy puppy or kitten in that newborn transitional phase from birth to life on the outside, as it were. So just resuscitation of animals born within the last 30 minutes or so. So kind of dealing with, should we be using doxapram? Is there any use in a pressure point on the philtrum? Should we be swiping out oropharynx versus providing positive pressure ventilation to these creatures? We're trying to answer a lot of these questions of the kind of newborn in distress now, and we're in the middle of writing that. So the evidence has been evaluated, and co-chairs Manu and I, as well as domain chairs, are diligently working through worksheets and hope to have that published in 2025, hopefully early 2025, if we can get it done. And soon following that will be some online material as far as coursework there. Also in 2025, we anticipate our first aid domain. So you're right, Justine. Recover is not only about CPR, it truly is about resuscitation and also just about high quality emergency and critical care in dogs and cats. So the first aid domain is all evaluated, and we're in the middle of reviewing evidence profile worksheets, basically. So the summary of what our evidence evaluators and domain chairs have done. Hope to have that published in 2025 as well by the end of the year, so that we can get some good recommendations for, is it worth inducing emesis at home, or should an animal just be put in the car and brought in when an intoxication happens, or an ingestion? What kind of bandaging or splinting should clients be performing at home? Things along, is an EpiPen worth it? So we have questions like that we're trying to address in first aid. And please don't quote me on those questions. I was not actually there, the co-chair in charge of that domain, but we're going to be working through those in 2025, hopefully to have those published.
Awesome.
Soon
Awesome
too.
information. Yeah. Again, I just wanted to reiterate the amount of work, the amount of criticalist work, the amount of review. I just want to thank all of you guys at Recover, especially Manu and Dan Fletcher. So much work went into it. And for those of you guys who want more information, please go to recoverinitiative.org. Great information there, great education. Dr. Jamie Burkitt, really appreciate all that you did for Recover 2.0, and looking forward to seeing what further evidence comes out of this.
Yeah, thank you so much. And I really appreciate the opportunity to come talk about our initiative. We really are passionate about it. I think it's really important for our veterinary community and for pet owners as well. And a huge shout out to all of the people. No one's being paid for any of this. So everyone, the veterinarians and the veterinary nurses and technicians around the world who helped make this a possibility, thanks to all of them. And thanks to anyone who's listened today and interested in learning more about Recover and evidence-based medicine for critical moments in the lives of dogs and cats. Thank you so much.
Love it. Thank you so much again. Really appreciate it.